Hello and welcome to this webinar on treating PTSD in veterans. When and why do things go wrong and what can we do about it? A very, very warm welcome to all of you who've joined us for the live activity tonight. And we've had an amazing nearly 2,500 registrations for this, which I guess is testament to just how important this issue is for those of us who work as clinicians. A very warm welcome to those of you who are watching us later on a recording. And of course, a warm welcome to our panelists, who I will introduce in just a moment. First, I'd like to acknowledge the traditional custodians of the lands across Australia upon which our panelists and our participants are located. And I'd like to pay our respects to their elders, past, present and future. My name is Mark Creamer. I'm a clinical psychologist in private practice and a professor in the Department of Psychiatry at the University of Melbourne. And I've had a very long interest in veteran and military mental health. And I'm repeatedly struck by my veteran clients about how complex they are and how, unfortunately, they don't always respond to what I know to be evidence-based treatments. And so it's a great pleasure tonight to be able to facilitate this panel and to pick the brains of our expert panelists. So without further ado, let me introduce them. Our first panelist tonight is Susan Burns. Susan is a peer support worker with Open Arms. She's joining us tonight from Canberra. Susan served with the Australian Army for 19 years in logistics, including deployments to East Timor. She medically discharged in 2011 and spent 3 years in the US before taking a job with Cooper House? No, Price, you know what I mean.
PwC.
That's the one. Working both in Canberra and in Washington. And she recently left the private sector to take this job as a peer support worker with Open Arms. And I should emphasize that Susan has stepped in at the very last minute today because our scheduled panelist, Lauren, was unfortunately unable to join us because she's unwell. So welcome, Susan, and thank you very much for stepping into the breach.
Thank you so much, Mark, and thank you for the lovely introduction.
It's a great pleasure. I like to ask people at this point what they like to do to relax, because we're in pretty stressful kind of work. And I hear through the grapevine that you've got one or two interesting pets. Is that right?
Yeah, so both my husband and I, my husband's still serving, but we decided to build our own little oasis, and we have 7 alpacas, 2 Dorper sheep, 4 Labradoodles and a lovely pony. So that's the way we relax.
Sounds wonderful. Do I need to know what a Dorper sheep is?
So you don't have to shear them. That's it's the lazy person sheep. Yes.
Wonderful. All right. Thank you very much indeed, Susan. Our next panelist is Phil Parker. Phil is a very experienced general practitioner with a large veteran practice in Brisbane. He served with the Australian Army for 28 years, initially in signals and in infantry, before retraining as a doctor and then later deploying to Afghanistan as a task force surgeon. As well as being a community GP, Phil is very committed to GP education, and he's the GP ambassador for Gallipoli Medical Research Foundation. So welcome, Phil. Good to have you on the panel tonight.
Thanks, Mark.
That was a big career change for you, wasn't it? What was it that made you decide to retrain as a doctor a little later in life?
I think it was a case of just wanting to extend myself a little bit further, and I've always thought that you know, a medical role is a role where you get to help others, and essentially that's what I enjoy doing. So, and I'm certainly reaping the benefits of it now, that's for sure.
Yeah, good, excellent. And I think GPs specialising in veterans or willing even to work with veterans are worth their weight in gold. So I'm glad that you're doing it. Thank you very much, Phil. Our next panelist is Richard Bryant. As one of the leading international experts in post-traumatic mental health, Richard really requires no introduction. Suffice to say that he's Professor of Psychology at the University of New South Wales. He's got an outstanding reputation in the field of post-traumatic mental health. He's got an enormous list of publications. And on top of all of that, in 2016, he received the Order of Australia. I think I really should be referring to him as Sir Richard. But anyway, welcome, Richard, and thanks for joining us.
Hello, Mark. How are you?
Very well, very well. Look, on a more serious note, Philip, among the myriad of projects that I know you're involved in, I know that you're doing some work adapting some of our interventions for people in developing countries under the auspice of the WHO. And I just wonder whether or not our approaches are able to be translated to these third world or developing countries, and whether you think they're useful for those populations.
Yeah, I think over the last decade there's been a big push for that, and we've certainly been doing trials that's telling us that it's working. In anxiety, depression, PTSD, and most of these countries that we work in, they don't have psychiatrists or psychologists, so we have to train the locals how to do it, basically getting evidence-based treatments down to the basics. And I'm literally just back from the Syrian border yesterday, where we're sort of doing trials in refugee camps there. So that's my way of saying, if I fall asleep in the middle of this, Mark, feel free to yell at me and wake me up.
I will certainly do that, Richard. But yeah, fascinating work and really important, I'm sure, a huge challenge. Thank you very much, Richard. Our final panelist tonight is Andrew Koo. Andrew is a very experienced consultant psychiatrist from the Toowong Hospital in Brisbane, where he's Director of Medical Services. Andrew has been seeing veterans and their families both individually and in the context of the PTSD treatment program at Toowong for nearly 20 years. So he's bringing a wealth of clinical experience to us on the panel tonight. And Andrew also holds an academic position at the University of Queensland. Welcome, Andrew. Thank you very much indeed for joining us tonight.
Thanks, Mark. Pleasure to be here.
As I said, you've been seeing veterans for a long time up there. Have you noticed any kind of changes in the clinical presentation of veterans over that 20 years?
I guess since we've started seeing the younger veterans, including the peacekeepers, so from the 90s onwards, prior to that, we'd only really been seeing the Vietnam veterans. And so what we've been seeing, I think, more recently in the last sort of 20 to 30 years is a more acute picture of PTSD. I'm not sure how different they are from the Vietnam veterans or for that matter, any of the veterans of previous conflicts who had PTSD, but definitely in the more acute picture, we see more anger, more acute anxiety, agitation. We probably see more relationship disturbance, more sleep disturbance, and probably more acute re-experiencing.
Yeah.
And probably also more substance use disorders as well.
But I guess it's slightly encouraging that people do seem to be accessing treatment earlier.
Absolutely, and we know that the literature will tell us that they'll respond better to early intervention.
Yeah. Good. All right. Thank you very much to Andrew, and thank you to all our panel. Let me just take a minute to tell you about this webinar series. So this is the 13th of 15 webinars that DVA has commissioned around the area of veteran and military mental health. We've run webinars in things like PTSD and anger, in sleep, in substance use, all sorts of things, suicide. And if you missed any of those and you'd like to see them, they're all available on the DVA at Ease website and also on the MHPN website. So do take a look there. Tonight we're using a new platform, and you may have noticed some slight differences in it. So we're all a bit on edge, hoping that it's not going to let us down tonight. But let me just quickly draw your attention to the fact that you've got a chat box there, the purple button. You've got a light blue button there to access the resources. I would suggest that you don't look at those while the webinar's on. MHPN will send you a link to all of those resources after the webinar, but you can have a look now if you want. The refresh button is the green button. The exit button is the red button. There's a help button there as well if you get stuck. And you can ring Redback directly. I thought the number would be on the screen, but it's not. So if you wanted to jot it down, it's 1-800-733-416 if you get stuck. And then finally, and very importantly, the yellow button there will take you to the exit survey, which we really do want you to complete before we finish tonight. So tonight we are looking at the challenges that we face as clinicians when we're treating complex cases, in this case particularly complex veteran cases, and when they don't respond as we think they should or as we would like them to the treatments that we know are evidence-based. What do we do about that? And we're going to use our vignette, our story about Brad, as a jumping off point. You've all had a chance to read Brad's story, and I'm sure that it rang a few bells for many of you. So we'll use that as a way of raising some of the issues and as a jumping off point for our discussion. But first, in just a moment, I'm going to get each of the panelists to talk very briefly about their particular perspective on Brad's case. And I say very briefly, they are all limited to 5 minutes each, and I will be extremely strict about that. So I guess at the end of the webinar, we hope that through that process, you're going to have a better understanding of when and why things go wrong, so the various issues that perhaps can get in the way of successful treatment. We hope you'll have a better understanding of what to do about it, so you'll be better equipped to know what to do when the evidence-based treatments are not working as we hope they would. And we think, we hope as a result of both of those, that you'll generally feel more confident about working with some of these complex cases. So, without further ado, let me hand over to our first panelist, Susan, to provide her perspective as a peer advisor or peer support worker with Open Arms. And I should say that Susan will be using Lauren's slides, so we're going to cut her a bit of slack and we're going to forgive her if there are any stumbles. But as I said, I am going to hold her to the 5 minutes. But over to you, Susan.
Yes, thank you, Mark. So we just want to talk about how peer support can help veterans. And when Lauren and I were discussing how we wanted to present this evening, I think it's really important to have some call-out words, because I think when you're talking to a veteran who has PTSD, and I have PTSD and I'm a survivor, and these words really resonated with us. So the ones that you can, everybody can read this on the screen, but the ones that really stand out for us as peer support workers are to engage. So promote a soft and relatable introduction and entry point to mental health services. So we made it actually be the first point of entry for a veteran suffering from PTSD when they call Open Arms before they see a clinician. And it's really, if we can get the veteran to engage, it's actually it's an extremely important step. The other one is the listen. So we provide a lived experience understanding and a level of empathy that we've had feedback that they feel there's no judgment. So there's nobody that's trying to fix them, and that's no disrespect to all the amazing clinicians on this webinar tonight, but it's about somebody being able to tell their story to a person who understands and has been through that experience. Not exactly the same, but certainly understands how they're feeling, suffering from PTSD and mental health. Destigmatise and reduce the shame, because when people are suffering, especially when they've been in the armed forces, where they've been expected to perform and wear especially for army officers, wear a mask and not ever show any weakness. There's a lot of shame that people have when they're suffering from mental health. And then from that, the normalise. So moving on to the next slide, the other words that we talked about that is to empower them and to feel, and that leads on from the shame. So to try and take away that shame or help them deal with the shame, and then provide them opportunities to empower, so that to inspire self-advocacy and self-directed change and recovery. And then we also provide that ongoing support, and that will be in line with the clinicians, provide an ongoing safe space and a connection as required. So they can come back to us, once there's a clinician who's been allocated to them, they can keep coming back to us and having conversations, and that's what it's about. It's about a framework and combined focus on helping them to recover. So I'll go to my next slide. So I have to click and read here. So also, how can peer support, which I'm sure some of you may not have heard of, I'm not sure how many on the webinar tonight know how much you know about peer support, but it's been extremely successful, we know, in the United States. We had a presenter here at DVA talking about it. They've got 1,400 peer supporters in the US, and it's been extremely successful. It builds that trust to utilise a common lived experience as a starting point to establish support, and I think that's really important, and I mentioned that before. It can often be the first step to provide that safe space for Brad to talk openly and honestly with someone who really gets it. Like, I've been there and I'm not judging you. The sharing the relevant aspects of life lived experience in an empathic manner and to focus on, like I said, destigmatising, normalising and the self-compassion, and helping him to discuss the practicality of living with the mental illness, accepting what he has, but being able to move forward into meaningful recovery. Finding hope, peace, purpose and pride is so important. And then assisting Brad to identify his strengths and find new ways to capture that inner peace. He says he felt that, he talks about it when he was serving, that, you know, he felt that connection and that inner peace. And there are other ways we have to help show Brad, we can help show Brad as lived experience veterans, that there are other things outside the military that can provide that opportunity.
Brilliant.
Mark, I think that's me done.
I think that is you. And particularly pleasing that you've come in comfortably on time there, which I'm thrilled about. I wonder if I could just ask you though, I mean, there's a whole lot of stuff there that's really important that we'll pick up on as we go through the night. Can you just say something about how we might be able to refer someone to a peer support worker in Open Arms? How does one go about that?
Yes, absolutely. So I'm not sure if you can see the advertising behind me, but the Open Arms number, there is the website as well, which is the www.openarms.gov.au, and that has so many resources. But the number, the 1800 011 046, and they can ask if they can speak to a peer support worker. And that can often be that very first step. So you can talk to a veteran who has been through what you've been through. Brilliant.
Great. And it's really important for our clinicians, our mental health providers, our mental health specialists to know about that, isn't it, and to be able to pass that on.
Yeah, absolutely. And we've actually found there's actually a lot of veterans out there that don't know about this. And it's a free service that can work in tandem with the support they're receiving outside of in the civilian world.
Yeah, brilliant. All right, well, thank you very much, Susan. We will pick up some of those in our discussion later.
Yeah.
Let's move on now and see if we can get a GP perspective and ask Phil, I guess, to talk about his reactions to Brad's story. Over to you, Phil.
Thanks, Mark. I just want to thank Sue there for what she offered, and she focused especially on the need for connections, and that's what a lot of these veterans are looking for. And the general practitioner is ideally seated to be able to open up some of these connections to find the best clinical team who are going to support these veterans, and that's imperative in general practitioner health. And obviously, I know that general practitioners are very busy people, but sometimes it can benefit if clinicians provide some information to the GP and really highlight the importance of investing a bit of extra care into these veterans. But with these sort of veterans, and I want to focus on Brad's story because it is typical of the stories we see out there. We need to make sure that we set up a relationship that's built on trust, and it's a regularly attended relationship. Okay, there needs to be regular follow-up, regular summarising about how they're going, okay? And with a lot of these veterans, it's important to understand the big picture, and that's where the general practitioner sits, okay? We know with Brad, he now has multiple physical conditions that he's dealing with, and they, within themselves, can have a significant effect upon his ability to engage with psychotherapies, okay? So they need to be addressed, dealt with, and make sure that their care, their management is adequate. Obviously, we know well about his mental illness, and we know that he has struggled to respond to the treatments that have been put in place. But as long as we've got a good psychologist involved and potentially a psychiatrist if necessary, we hope that side of treatment's being taken care of. We know with Brad, he relies heavily upon substance to aid in his functioning, and that's a major concern. And that's going to provide a barrier, okay? It may not be something that needs to be addressed immediately, but it is something that will need to be addressed. And until it is addressed, we may not get the success that we're looking for with some of the psychotherapies. The next point I want to talk about is assessing what's happened in the past. Often these veterans will go from clinician to clinician. and it's important that we have some sort of history about what's been attempted in the past in terms of interventions, because we don't want to repeat those failed interventions. So we need to try and, and a GP is ideally is in an ideal position to be able to source some of the information. We know Brad is a TPI, so he can't work, but that doesn't mean he should just hold himself up at home, isolated socially, okay? There are some things that a lot of veterans can do, even in a volunteer capacity, and that's really beneficial for their care. The next point I made on that slide there is about reviewing the current treatment team arrangements, okay? And a lot of these veterans, they won't have a team, okay? But it's important that we recruit that team that provides them with the best support available. And I know in Brad's story, when we read about it, I personally thought the intervention of a social worker would be ideal for him. It's an extra person in that team, that network that's supporting him, okay, and trying to motivate him. And the last point on this slide is we need to know what his motivations are. We need to get him on board, and we need to want him to get well, and to him to be focused on his therapies. Let's go to the next slide now. Okay. So in order to do this, it's important that GPs arrange regular reviews. Okay, they need to provide these veterans with an adequate amount of time. Okay, with a lot of them, 15 minutes is just not enough, especially with complexities such as Brad has here. Okay, so we need to schedule those in advance. We need to allow him time, and it's often good to sometimes summarise what's happened today, to reassess how we're going, whether we're making any progress or not. Okay, there's a lot of veterans out there who don't have a DVA white card, or they don't have a DVA card at all, and it's our role as general practitioners to make sure that their DVA entitlements are maximised, and that opens up a whole bunch of new medical interventions that are possible. This is a difficult one that I've found as a general practitioner, but we need to always try and encourage regular communication between all members of the team, so that we all work off the same sheet of music in terms of trying to provide benefits for the veteran. Okay. And the last one is the social engagement. It's really, really important. And we know in Brad's story, he now avoids social environments. He's hiding himself away at home, and we know that this has poorer outcomes. And it's certainly going to have an influence on whether he gets well. Sorry, I'll just click. I know I've only got 5 minutes. My final slide. Always, for general practitioners, it's always important to remember the carers, okay, the spouses, the family members, or even close companions, the people who support the veterans who are struggling. They've, for many of them, especially spouses, they've had to endure the burden of living with someone with a condition such as PTSD, and they themselves can often experience long-term carer stress, and they may have neglected their own health as well. So it's really important that that's looked at, making sure that that's being addressed. But I suppose the key message is with a lot of these veterans, they're really complex, they're really hard work, and we should never expect to get good results in the short term. We need to remember it's a long road, okay, and that's why I put there: patience, positivity, and persistence. Thanks, Mark.
Right. That's a good message to leave people with, isn't it? Thank you very much indeed for that, Phil. Just quickly, I would like to pick up on a point you made there about the fact that some veterans, perhaps many veterans, are not engaged with DVA, and I guess there is, as you said, so much that DVA can offer veterans, but some veterans are reluctant, I guess, to engage with DVA. Is there anything that we can do about that?
I think we need to find out why they're reluctant to engage. Maybe it's because they're trying to separate themselves from anything to do with defence. I'm not sure, but we need to encourage them to understand that although the DVA processes can be quite demanding and a bit frustrating at times, with the right support, that we can activate the best processes to get the best care. So we need to try and sort of slowly try and work that perspective to make them more motivated to accept DVA support.
Yeah, thank you. And we will certainly pick up on a whole lot of those points that you raised as we move into our discussion. But thank you very much indeed, Phil. Let's move on now and hear a psychology perspective from Richard on Brad's case, and maybe a little bit about why perhaps Brad might not respond so well to our evidence-based treatments. Over to you, Richard.
Okay, thanks, Mark. Now, my screen of course, is frozen, so I'm going to ask the people behind the scenes here to sort of move the PowerPoint for me. And on the first one, I think my first reaction to Brad's presentation was just how chronic his presentation was, which of course is common in veterans. And whatever else he's presenting with, and he's got an array of comorbidities, I think what came across to me was the depression and the helplessness and probably the hopelessness that he's presenting with. And when he talks about things like, he hasn't struck a blow since he's left defence, it wonderfully sort of reflects sort of the misery and the pessimism that he has. And for me, this is a huge issue when we talk about trying to get him moving again, because anybody that just doesn't have the basic optimism for getting better, and he's got nothing really positive that is in his scenario about what's going on in his life, it just reinforces this sense of helplessness. And I think this is highly problematic in these cases. Moving on to the next slide. For me then, what we've really got to try and do with Brad is try to, first of all, try and get an expectancy of recovery. I'd be concerned that there is a sick role happening here, that he's learning as time goes on, that I'm not well, I can't get well, people are offering me treatments and I'm not getting any better. And it seems to be digging a deeper and deeper hole. And I think the sense of anhedonia and the lack of positive that's going on in his life, to me, is a real worry. Because when this becomes chronic and long-term, it's hard to help a person get out of that situation. Now, we actually, interestingly, there are treatment innovations going on around the world at the moment that are shifting us away from trying to reduce negative symptoms and trying to improve the positive aspects of people's lives, actually training people to savour, if you like, and get in touch with positive affect. And I think this is the sort of thing that Brad may need, because it just isn't there. And I do think, reflecting what I think Susan said earlier, I think his identity is central to this, because he had an identity in defence. He seems to lack it now, and I think we really need to help him regain that. Moving on to the next slide. I think one of the issues is, has he had evidence-based treatments? We all talk about cognitive behaviour therapy and how wonderful it is. But I guess one of the questions for me was really, what is the primary presenting problem for Brad? Does he actually have PTSD or depression, or is it something else? It's actually the primary problem. And I think often we jump to the conclusion that people need trauma-focused therapies just because they have been through trauma, just because they're a veteran. But they could have a whole range of issues. And it may be the depression, it may be the anger, it may be the panic, the agoraphobia, many things that he has. But these things can get in the way of the success of trauma-focused CBT, and they may need to be dealt with before we actually deal with anything else. And I think automatically providing a standard off-the-shelf PTSD treatment, when it really might not be the right thing to do, it just can't leave a veteran feeling like a failure, because they feel like they've been offered something that people are talking about as the best treatment, but they haven't responded to it. And then moving on to the last slide, I think in terms of treatment options, I'd just be wanting to be really clear with Brad, what are the clear and short-term goals for him? Again, I want him to have success in whatever we sort of set for him to do, because he hasn't had a lot of it lately. I want to discourage this sick role, and for me, and I know others may disagree with me on this, I would probably want to prioritise an outpatient program. I realise that if he becomes suicidal or there's substance dependence or something like this, then he needs an inpatient stay. But I would like to keep him close to his family. I'd like to keep him functioning as any way he can, close to his friends, with the sense that he still is actively engaged in life and working with him on an outpatient basis. And I guess the final point I'd make is that I'd want to be treating his problems and trying to improve the positivity in his life, rather than just focusing on a diagnosis. I think too often we give people a diagnosis and we think, let's just give them an off-the-shelf treatment for that. But I think Brad is a great example of someone with very specific problems. I think we need to identify what they are and we need to focus on those. And Mark, I'll finish there.
Thank you very much indeed, Richard. Again, all sorts of really good stuff there that we will pick up in our discussion in just a minute. But if I can pick up on that last point, because I was thinking of it all the way through as you were talking, really, and that is this idea that we're hearing a bit about now about transdiagnostic approaches to treatment. Well, I guess the idea that we're treating dimensions of the clinical presentation rather than, as you say, focusing just on the diagnosis and saying they've got PTSD, so we must do that. Are we making progress in those kinds of transdiagnostic approaches?
I think we are. I think it's slow. All things are slow. But it's not just transdiagnostic. I think what we're getting towards is identifying that within a diagnosis, there's often different problems. So you might have rumination, you might have suicidality, you might have social problems, you might have relational problems, alcohol, whatever. We do have evidence-based strategies to deal with these. And I think the trick is identify the evidence-based strategy that's best going to address a particular person's problems, help them learn those strategies, because that's probably what's going to be best tailored to their needs rather than just a whole big package. Yeah, quite.
Okay, thank you very much, Richard. We will come back to some of that undoubtedly. Let's move on now to our final panel member and get a psychiatry perspective, perhaps a little bit about medications, perhaps a bit about the PTSD treatment programs. Over to you, Andrew.
Okay, thanks, Mark. So first thing I want to say is that I agree completely with virtually everything on all the slides we've seen so far from the others. It certainly shows the importance of a collaborative, multidisciplinary approach. Because what I'm going to be talking about today is more, I'm going to try and shift a bit, onto a psychiatry focus, but all that other stuff is very important from my point of view as well. So the first slide really is about, so this is showing that this is, first of all, I just want to say this is capturing the case, this typically chronic and complex presentation. Okay, this is a difficult case to work with, but something that's not unusual from what we see when we're out sort of treating people day to day. Just very quickly going through that, this is a PTSD picture, but there's definite psychiatric comorbidity there. So it's complex psychopathology. There's depressive stuff there. There's alcohol and drug abuse stuff in there as well. Like Richard says, it's difficult. We'll have to tease out what's primary, what's secondary, what's most important. There's comorbid physical problems as well. He's got a history of child abuse and neglect, which we know predisposes individuals to mental health problems later on in adult life. Due to his medical discharge, we have problems with loss of role, purpose, meaning, loss of identity. He's also got additional, then on top of that, financial difficulties, relationship strain, parenting problems, and relative social isolation. So a complex picture, but not unusual. In terms of treatment considerations, a couple of things to consider that certainly from a psychiatric point of view, we do need to consider the potential for does he require inpatient management. I would agree with Richard that this should be a final step and we should try and exhaust all our other options first. But when we hear statements like everything is crashing down around me and things are coming to a head, these are things that start to raise our concern that he's really crying out for some kind of more acute help. So we decide whether someone needs to be admitted based on their acute risk to themselves, their risk potentially to others. And in Brad's situation, we would be concerned that this could be the case, and also the potential involvement of family services and the potential risk to his children is something we really have to consider as well. The other thing we have to consider is if we don't admit him, is he acutely going to deteriorate symptomatically. So that's another reason we might bring him into hospital even without the risks. So hospitalisation allows close monitoring, rationalisation of his medication. It allows multidisciplinary input with increased access to the patient more often. You can do more sessions and see them day to day, watch for improvement or otherwise. We can detoxify him, we can mitigate risk to himself and his kids and give him and his wife some space. We can start setting up outpatient or discharge planning, setting up his outpatient management as he leaves. We can get second opinions, and we can also organise networks for his discharge that involve a lot of other people as well. So from a point of view of medication, we know that all we've got from the vignette is that Brad's been on a lot of, that he's seen a psychiatrist and that he's been having several years of medication management, but we don't know anything about what agents he's used, the dosing, the duration, his adherence to the medication or not, and then, you know, the impact that substance abuse may have had on the effectiveness of the agents. Has he, what agents has he used in combination, or has he used them just as monotherapy? We need to measure this whole medication history against the evidence base and what the evidence base says about the relative effectiveness of each of those medications. And then we need to start developing next steps focusing on his symptom sets and tailoring the medication to his individual hierarchy of needs. So again, as Richard says, rather than just going purely on a diagnosis. And finally, something worth really considering is the trauma recovery programs, which are accessible around the country and all covered by DVA. DVA will even put people up locally, close to the hospitals, so that they can attend these outpatient day programs. These have been running for 25 years, are well validated as being effective and annually accredited against developed standards, which have been developed by, you know, the clever people at Phoenix. So these are closed groups with inbuilt individual sessions. There's multidisciplinary input as part of the course, and all the staff are trained in specific evidence-based therapies which target PTSD. They're comprehensive, they involve other aspects that are often important, like regular exercise, meditation, yoga, relaxation. Some have art therapy, some have some animal-based therapy as well, and they certainly involve well-developed assessment and discharge processes, and they work well with established forces that are helping patients in the local areas. So in thinking about time, I'll leave it there.
Thank you very much indeed, Andrew. And again, all sorts of great points that I'm sure we'll pick up on again in our discussion. Can I just pick up on the idea of the trauma recovery programs and the fact that they are group-based and that we're treating veterans as a group? Do you see there's any advantage to that in terms of perhaps leveraging off their military experiences of unit cohesion and support? Do you think the groups might work particularly well for veterans?
Yeah, I think veterans are a group that really respond very well to group therapy because they're trained in teams and they're used to being in teams, and also because often when they're transitioning and they leave the military, and often when they're in the military, they prefer to be around other people with shared experience, people who they can trust, can work in teams, etc., and people that they respect. So certainly also the general group sort of aspects of support, normalisation, external motivation, all these things additionally also help, Mark.
Yeah, great. Okay, thank you very much indeed, Andrew. Let's kick off the broader discussion now. And I'm going to ask all our panellists to just jump in whenever they want to. I will direct questions at some of them, but please, to all of you, feel free to jump in at any point, disagree, or at least add an alternative perspective whenever you want to. I must say that I've been extremely impressed by the number and the quality of questions that we've received from you, our participants. I would love to be able to make sure we get through every single question that participants have raised, but we have had many, many questions, and we're not going to have time to get through them all. But I'm confident we will get through the main themes, and if we don't get to your particular question, then please bear with us. But I'd like to start the discussion, if we could, by thinking about the area of, I guess, etiology and assessment and really formulation, and I guess working from the assumption that, particularly with complex cases, being able to formulate the case, being able to get a clear understanding of why this person is presenting at this time with these problems is really important in driving our kind of management and treatment plan. If I could turn to you first, Richard, I don't know whether you're back on screen, but if I could ask you a little bit about the role of social factors, perhaps in Brad's presentation or someone like him. I guess the role of family, friends, peers in terms of Brad's adjustment. Any comments on that?
Yes, well, I think it's both in terms of etiology and maintenance. I guess they're the two things we normally think about in a problem formulation. And I think, as Andrew mentioned earlier, Brad clearly had attachment problems as a child, given his upbringing. That certainly predisposed him to having a personality that is more likely going to probably be vulnerable to social problems that emerge later. Now, I think what's happening now is that I suspect he had a great sense of family and connection in defence. He has lost that. He has lost a lot of the innate social networks that exist in defence, which often happens when people transition. He seems to be withdrawing from friends. The family that was initially very important to him tends to be a source of frustration and anger now. And I think this has become a major maintenance factor in his condition, and it's contributing to other problems. And I think why I emphasise the word maintenance, I think is the whole point of having a problem formulation is working out where are we going to intervene. And I think intervening on some of those key social levels is really important. And I think intervening immediately at a family level, I think, would be very important. I think thinking about Brad's parenting skills, I think the extent to which he's actually relating in a positive way with his children, rather than just being the disciplinarian, having a positive relationship with his wife. This sort of things need to be nurtured, because if we can go to therapy and he can see a therapist maybe an hour a week, his family he's going to see 7 days a week, 24/7. Yeah. And the amount of positive feedback that he can get from them far outweighs what he can get from therapy.
Yeah, quite. And, I guess all of you really, but I know certainly Phil and Susan in particular have talked about the importance of social engagement and so on, which you're picking up on. Of course, we will come back and talk about treatment a bit more in just a minute. Can I come to you, Sue, here? And at this stage, given that I'm trying to think about the sort of etiology or perhaps the causes or what might have contributed to Brad's presentation, ask you a bit about transition. We haven't. This is a participant has asked me a question about this. We don't have much information on Brad's transition, but how important do you think it is that the process of transition is managed well in terms of setting up the veteran for their subsequent adjustment?
Oh, it's absolutely critical. It's absolutely critical for veterans as they transition out of the military. And as a veteran who, I have a husband who's still a serving member and a lot of friends who are still serving, and I have a lot of colleagues who have transitioned. We're still not good at it. Unfortunately, if you're medically, which Brad has been injured, he's lost sight in one eye. He was an infantryman, so he probably was in, I would say, Phil, jump in if you think I'm wrong here, but more than likely he was probably in an operational unit or an infantry unit. Once he sustained these injuries, he wouldn't be able to do the job he had been employed to do on a day-to-day basis. And as he's doing his medical discharge, which may have been over several months, because he can't be discharged until Defence feels that he is medically fit enough to be discharged, and also all of his DVA paperwork needs to be submitted if he chooses to submit DVA paperwork. So he's given the information, but he is not. They can't be forced to submit paperwork to DVA. However, it takes the doctor to sign off and say that Brad is in a position to be discharged. However, what probably would have happened to Brad is that he wouldn't have been able to do his job, and he would have been literally put behind a desk and told to do some admin work while his discharge was being processed. And this is where the shame would have come in, and the detachment from his colleagues. And he's already been discharged from as far as the military is concerned, but he hasn't made the transition.
Yeah,
and there's a lot of talk about how we do this, that because quite often it's DVA that has to pick that up at the other end, or the clinicians, the people, like yourselves. So it's actually, there is a lot of work to be done around the how we treat our veterans who have been discharged, or our service members being discharged. Yeah, it's a very complex problem.
How we negotiate that process of discharge. And you kind of allude there to vocational rehab, which is something I do want to talk about later. Can I move on now, just thinking about Brad's presentation and the kind of different aspects of it, and maybe bring you in, Andrew, if I could. How important do you think that substance abuse has been or is in understanding Brad's presentation? I guess it's not uncommon to see a fair bit of substance abuse. Is it important in driving aspects of the presentation?
Oh, it has a complex. It is very important, and it has a complex relationship with their other psychopathology. So, in other words, their primary mental illness, and like we said before, be that PTSD or depression or whatever, with Brad, the substance use problem, which we know is alcohol and the iatrogenic substance use problem of the opioids, which he initially got treated with for his chronic pain. So the complex relationship is either like what's coming first? Like is his medication use, his medication being the opioid and the alcohol use, is that worsening his PTSD or MDD? Or is his depression and PTSD actually the primary problem that's worsening the substance use? We need to kind of work that out. And the substance use, if it is contributing, is how is it contributing? Is he using it, for instance, to manage other symptoms that might even be sort of separate from his actual PTSD or MDD, in that has he got primary insomnia? Is he using it to manage the distress he's getting from the relationship problems, or the difficulty in managing the children, which there's sort of some indication that could be the case? Is he using it not because of his mental health problems, but because of his boredom or his loss of meaning or loss of role identity that's happening just as a result of his transition? Is it something that he was perhaps using alcohol, was something that he picked up when he was in the military, and he sees that as an appropriate coping mechanism for any kind of stress? So we need to work out where it fits in, why it's happening, the extent of it, and is it primary or is it secondary?
Sorry, I was talking away quite happily there, and unfortunately I was on mute. That's a real rookie error, isn't it? So I can only apologise to everybody there. And I've got a big sign.
Mark, we just assumed you were stunned by Andrew's wisdom.
Well, there was a part of that as well. That's quite true. Dear, oh dear, that's a real rookie error. Anyway, look, let's get back to it. What I was saying, Andrew, was that first of all, that it highlights how important it is to do this thorough assessment, which everybody has spoken about. I agree entirely. But I also wanted to actually bring Phil in, because I wanted to talk about the fact that, as you started to talk about, Andrew, that the role that opioids are playing, But I'm also interested in your perspective, Phil, on the impact of his physical injuries. How much does it complicate the picture when we've got serious physical injuries as well as mental health problems?
It has a significant effect. We know that Brad suffers chronic pain, which is likely related to his permanent injuries. These have a direct effect upon his motivation, upon his mental health, and he's obviously using opioids to help manage that pain, you know, and potentially as a coping mechanism as well in terms of his mental health. It's certainly not sustainable, and it is something that needs to be addressed. And you know, when there's a significant opioid dependency or even alcohol involved, we hope that that's where a psychiatrist involved may consider it an inpatient period of time just to try and sort of rebalance that. I think some of these veterans, because especially with him, he you know, I look at Brad's situation. He's got a lot of empty in his life. Okay, you know, we look at his particular injury which occurred in 2015. He was separated the next year, so he's gone from a high-functioning individual, infantry soldier, to a man who struggles to function generally, socially, vocationally. So his self-esteem is certainly at an incredible low. So he's trying to fill his life up with other things. Okay, so you know, it's important that we address opioid dependency. It's important that we address everything. We need to surround him with people who can bring out the best in him. We know that it's going to take time, but we need to motivate him. We need to focus especially on the things that are important to him. A lot of these veterans will present when things have reached a head, and for Brad's case, it may be because of his wife Donna, who said, "No, I've had enough," and that's often what we see, you know, in general practice. They'll present after things have, you know, when marriages are about to break down or partnerships are about to end. Okay, and so we need.
I was just going to ask about, you know, sticking on the physical injuries. One or two of our participants have sent in questions asking about, does, for example, an amputation or a serious ongoing physical disability, does that compound the mental health problems? Does that make it worse, do you think?
I think it does, but I think it does because it's a permanent reminder that they're no longer the person that they were. You know, it's harder for them to function, especially vocationally, you know, with work. It has a big effect, yeah.
Yeah, okay. Richard, if I could come back to you, we've I guess already highlighted a number of reasons why Brad may not respond to treatment. But have you got any ideas from a psychological perspective and from what we know about evidence-based treatments, as it were, any comments on what reasons there might be why he wouldn't respond to an evidence-based approach?
Well, first of all, let's be honest and say, you know, a half of people or a third to a half of people don't. So he's not that unusual. And the more complex the presentation, the more likely somebody will not respond. So I wouldn't be super surprised that he hasn't responded. I think it's probably because, this is a guess and I don't know enough of the details of the case. I suspect he's been given a standard treatment like prolonged exposure or something like this, or cognitive therapy, and he hasn't responded. I think it needs a far more astute assessment of what his specific problems are, taking into account the social context of his family and everything. And I would particularly be focusing on what are the most difficult things that he's presenting with at the moment. And I'm not quite sure what it is. But I would want to dig deeper and find out, is it the panic that's driving the agoraphobia at the moment that's causing him to be withdrawn? Or is it the explosive anger? I would like to find something that is actually both causing him a lot of grief, but at the same time I think we've got a window of an opportunity to make some gains in. Because what I just would reiterate is we want Brad to have some therapeutic success. And I don't know where that's going to be, but he's got to have success. So if we've tried a trauma-focused CBT and it hasn't worked, I wouldn't just keep hitting him over the head with that. I would go to plan B and try something else. And I would actually try one of the other clinical problems that he's got, so at least he feels he's making clinical gains.
Yeah. So what people are saying, what you were saying earlier, is that even at a starting point with someone like Brad, being really cautious about jumping in with prolonged exposure straight away, that really we should be addressing some of this other stuff. Thank you for that, Richard.
Hang on, Mark. I would say, though, that if he's got clear re-experiencing and that's the primary presentation, I would jump in with prolonged exposure.
Yeah.
But that's if. But that may not be the problem.
Yeah. Yeah, and exactly. And so just because he gets across the line for PTSD doesn't necessarily mean it's got to be exposure. Can I come back to you, Phil? Because I guess that your GP is often the first line, if you like, that veterans will come to. And I guess we know, and I think Brad is really, that a lot of them are fairly poorly motivated, that they can be quite uncooperative, they can come across as being aggressive. Do you have any thoughts about how we might engage someone like that in treatment initially?
With these type of veterans, often we'll find them and they will not want to engage in other therapies. Okay, so they're always looking for those connections, and sometimes we need to try and find out what their motivations are, and we need to arm them with an understanding that they can get help. There are therapies available, and even just plant that seed and just sort of nourish it over time. And I think generally in time they'll go away, they'll think about it, they'll talk to their family, and if they understand that these are therapies that have the potential to improve their mental health condition, they will eventually, express a willingness to try.
Yeah. Yes. Okay. Good. Can I come to you? Let's go to Andrew. I guess one of the things that everybody has said, and is blindingly obvious from Brad's story, is that there are a whole range of factors. There's a whole range of things going on here. And we know that we're going to need to address probably all of them at some time. And I guess the question is, which is the best point to start? And Richard was saying there, I think he was saying really about, one starting point might be what does Brad think is most important? But do you have any guidelines for clinicians there when you've got this really complex mass of things that you should be working on, how you work out where to start or how you work out a kind of sequence of priorities?
Okay, well, that's a really good question, and it's a question I think a lot of people struggle with. But I'll tell you exactly what I do. Say in my rooms, if I was to have seen him as an outpatient, what I would do is, in my own mind, I list that problem list that we saw before. And what I look for, I'm working on rapport and engagement from the beginning, because this is a really critical key that we've already brought up, and Phil answered quite well there. But one of the most important things in terms of getting effective treatment with veterans is engagement, and then being able to keep them in therapy so that they get an appropriate dose of whatever kind of therapy we're going to do. So part of that all feeds into how I sort of develop a problem list and move forward. So what I'll often do, Mark, is I'll look at things where I can get quick and easy wins in terms of whatever their problem list is. And they are often things, and that quick, what I mean by quick is when I see them sort of a week later. So what I'll often do is I'll say, okay, well, he's got the drug problem. Okay, so we'll try and plant the seed of how important it is that we get control over this. And if we can do it as an outpatient, I will give them some, say, substance use goals to meet between now and a week when I see him. If, for instance, he's got terrible insomnia and that's really causing a lot of the problems, what I will do is I can prescribe, for example, a simple, safe tablet that will help him sleep, and at least when he sees me in a week, he'll get some confidence that we can get some sort of short-term wins happening. To other clinicians out there that aren't doctors, what I would say is you would then say, well, if sleep's a major problem, you refer them to the GP for a mild sedative so that at least you can get on top of the sleep and get another thing out of the way. It builds trust. It builds you start building little successes. So what I'm doing is I'm not trying to diagnose. What I'm doing is trying to find the main problems, seeing which ones we can get quick wins with, and stepping in as quickly as I can with those kind of things.
Yeah, absolutely. The quick wins which are going to make him feel more positive and more that the treatment is actually useful. I think it's a really good point as well, and I think it's one that Richard made as well. So looking for those, I won't say easy, but the quick wins so we can get some gains. Yeah, very good point. We're talking about how difficult it is, or we have been talking about how difficult it is to engage people. And I'm wondering, Susan, whether, well, I guess two parts really. First of all, whether we might see peer support workers as being a way of engaging, that they might help to engage the veteran and almost be a stepping stone to introducing them to more specialist care. So that's the first part. And then I suppose the second part is whether they might stay involved as the person does, a psychiatrist or a psychologist or whatever, whether the peer support worker might stay involved. But the first part is, are they useful, do you think, in helping to engage veterans in the first place?
I personally think that they're absolutely critical. I think that it's really important with someone with who presents with so much complexity as Brad, that who doesn't want to talk to anybody, that having another veteran to talk to may actually be the first step to getting him the support that he needs. The mental health peer work complements, though, the clinical intervention. It's not the only solution. I think it's the first step, and it also can be an ongoing process. So Brad can check back in throughout his recovery with the peer to talk about different things that he's feeling, and I think that's a really important process. I think we need to think about the word complementary when we talk about peer support. But I think what you mentioned there is the criticality of it is that it can actually be the first step to helping Brad to get help.
Yeah, quite. Was someone else trying to come in there?
So I was just going to say, Mark, as well, the other thing that Open Arms does, and also the peer support, we also have family members as well who are peer support workers. And so it would be help for Donna in this situation, where she can talk to somebody, a family member, who's maybe been through the same, or who has been through the same situation or a similar situation, to get the support.
Absolutely. I mean, family, actually, that's a whole thing we should be talking about as well, really, isn't it? About the role that families play and how we should engage families, or whether we should engage families. I might throw that at you, Phil, actually. How important is it, do you think, to engage the family as well, and as part of the veteran's treatment almost?
We all know the importance of family and involvement in the veterans' care, and I mentioned earlier about how often they've had to bear that burden for such a long time, So it can be difficult. Some veterans don't want their partners, their spouses, or family members involved in their care, and that makes it a little bit tricky. But if we can, they are valuable tools to have involved, okay? Because they can often support the veteran through any clinical interventions. They can provide reminders. They can ensure that they present for medical appointments and that they meet their clinical expectations. So we of course, with looking after these veterans, we need the veterans to stay central. We need them to be central to the decision-making process. But the close family members, especially the partners, they need to be heavily involved, because they are an incredibly valuable clinical tool for us.
And usually, are they willing to get involved, in your experience?
Absolutely. Often it's that they force the veteran to present to the health provider, whether that's a GP or a social worker or Open Arms, because they want something done. They see the situation at home and they think this is not sustainable. Something needs to be done, and they're generally always on board and strongly supportive.
Yeah. Okay. If I come back to you, Sue, just a minute. I guess a lot of people have alluded to this, but are you able, or how important do you think it is to engage Brad in other activities and there may be other social activities, they may be, I don't know, sporting activities or whatever. Is this something that you think is important and something perhaps the peer support worker might help with?
Yes, certainly, and you would see that there's a great deal of work being done, not only through DVA, Open Arms, but with you, with me, Soldier On. There's a lot of organisations out there who are starting, doing different activities now. There's a yoga for veterans. There's equine therapy. There's a lot of activities that are being, and there's a lot of funding being put into different activities for veterans. So, for me, part of my recovery and the framework for my recovery was actually going out and finding interest and hope through other activities, so yoga, Pilates. But you also, I think there's the really great groups out there that they're getting veterans together to support other veterans, and this is this peer support piece again. So they're joining other veterans, and a lot of these veterans have physical or mental disabilities, and they're coming together and supporting each other. So that says a lot.
Absolutely. I guess we have such an enormous body of literature over many decades now, not just with veterans, but generally speaking in psychological health and well-being, about the importance of social support and how helpful it can be. So, yeah, look, I'll go along with that. Time, unfortunately, is against us, and there's a couple more questions that I want to ask. Andrew, can I just ask you very quickly, it's a massive issue, but I think it's so important, about the issue of occupational rehab. How important is it, do you think, that we're helping Brad to get into some kind of meaningful activity, some kind of ideally paid employment, but if it's not paid, maybe voluntary, something meaningful? Is that important for him?
It is. I think it's a keystone tenet to the holistic treatment of PTSD, and in fact any kind of chronic mental illness. Interestingly, if we look in the scenario, Brad says that he really loved the adrenaline rush, the team spirit, the purpose, the structure and containment that the Army offers. I mean, he's going to get that if we can find for him the right type of meaningful activity to do in the day. So whether it's actually vocational rehabilitation or whether we just find him some other meaningful activity is key. We did some work on looking at veterans with PTSD, and we looked at people who were unemployed, and then we looked at people who were on TPI. TPI seeming to be the kind of holy grail of where you want to get if you are really medically compromised. And interestingly, we found with the group on TPI and unemployment, they had the same amount of suicidal behaviour. So really this underlies the purpose of that it's just so much more than material money. It's all about purpose. It's all about direction, the reason to get out of bed in the morning. And it's just crucial for anybody's psychological health.
Yeah. I agree. And not enough attention paid to it so often, I think. I'd like to just now, in the last few minutes, pick up on something you said, Susan, but I'm going to chuck it at Richard first, although I would actually be interested in everybody's views about it. And that is around the area of what we might loosely call alternative treatments or adjunct treatments. And it's not so much about, although you might want to comment on how effective you think they are, but it's more about, do they have a place? Do they fit anywhere? And whether that's things like, some participants have asked about things like martial arts training, equine-assisted therapy, which you mentioned, Susan, massage, yoga, outward bound programs, and so on. Richard, do you think that there is a place for them?
That's a great question to ask with 2 minutes to go, Mark.
Yeah, exactly.
Yeah, probably why you asked it. Look, in essence, I have an open mind to everything. I personally think we're so desperate to find things to help veterans. I think sometimes we're too keen to embrace programs, alternative programs, and we jump on them with gusto. Now, that's not a popular thing to say, but I do think that whatever we provide to veterans, I think we have to prove that it works. So I think everything has to be evidence-based. And that's a hard ask because you've got to demonstrate that is it effective relative to what we currently have that's the best treatments or programs available. I think in a lot of the alternate programs being offered at the moment, I think there are mechanisms at play, and I think that's what I'd rather be focusing on. So I think there's social connection, for example, or there might be physical activity, or there might be self-mastery. I mean, these are the things that are embedded in a lot of these other common programs. So it might not be the thing itself, but it's more that mechanism that's driving.
Yeah.
That's what I'd like us to learn more about.
Yeah, quite. And I guess also, though, to be clear about what the goal is, and many of them perhaps are marketed as treatments for PTSD. Maybe they're better seen not as that, but as strategies to kind of improve well-being, improve quality of life, or whatever. Does anybody else want to jump in? You literally have about 20 seconds to do so.
Yeah, Phil here. Can I suggest that they are more motivation factors? We know that these veterans, they need to be motivated. They need to stand up and to be able to sort of get control in terms of their own treatment, you know, and getting them involved in activities. And look, there's different activities for different veterans. They all, you know, equine therapy might not work for all of them, okay? But if we can get them involved in something that they're interested in, it helps fill up their day, it gives them purpose, then we have greater chances of achieving success with other therapies.
Yeah. Yeah, no, I think it's a very good point. It's a very good point.
So, Mark, I'll just say one more thing about that, and that is that generally, when we look at evidence-based, where it's a sort of a medical model where we're finding symptoms or symptoms or diagnosis, we're applying a manualised treatment that can be measured and can be kept fairly homogenous, so we can say we're giving the same thing to everybody and we're measuring it and seeing if it's working. Okay, that's about symptom improvement, and it's very different to, I think, what we get from all these complementary treatments, which is all more life enhancing. So it's almost like background life enhancing, like you were saying, quality of life and well-being. But all this stuff is very important in mental health, because that's about focusing on what makes life better, and that protects us against mental health, but also helps us improve when our mental health isn't as good.
Yeah, absolutely. And as Phil says, put someone in a much better position, hopefully, to then make use of the treatments that are available. Yeah, look, maybe I got onto that one a bit too late, but I didn't want to spend too much time on it, so I deliberately waited a little bit. Now, unfortunately, I can't change slides at the moment, but maybe if someone else who can change slides can move it to the next one for me. I do need to wind up things now, but can I just turn to each of the panel members and ask them to give me a kind of just any brief take-home messages for participants, just very briefly. Susan, do you have any brief take-home messages?
I do actually. I'm going to change that a little bit, and I just wanted to say, because I know tonight that all the participants and all the panelists are clinicians, and as a veteran, I just want to say thank you very much for the work that you're doing. I know that sometimes it may feel thankless, but the work that you're doing from a veteran's point of view is absolutely critical, and it saves lives. And I just want, just when you're having a hard day, remember that all of your work is extremely important, and we really are very grateful.
Thank you for that, Susan.
Yeah,
thank you for that. I think that's a very nice thing to remind the clinicians who often it doesn't seem as though the work they're doing is that easy. It's not that easy, but to get that I think is really important. So thank you very much for that, Susan. Phil, any take-home comments for people?
Yeah, we all know that these these cases are quite complex and they're difficult. Okay, and that's a lot to for us as health or as clinicians to try and manage. I think as long as you have the veterans surrounded by people who bring out the best of them, the best clinical team that you can recruit, and just an understanding that it's just going to take time.
Yeah, good advice. Good advice. There's no quick fix. Okay, thank you, Richard. Any take-home messages for people?
I think my message would be to those clinicians who are lone clinicians and probably dealing with cases like Brad without a bigger team around them. These are really, really tough cases. And I think it's really important to get supervision and to get advice and just to be able to brainstorm with other people. And I think if you can't do it, if you don't have them available, there are services available like the Phoenix practitioner support service. And I think if you can access things like that, it's just good to get the more input you can.
Yeah, good advice, Richard. Thank you very much for that. And Andrew, any final quick comments?
Right, fine. Final quick comment about treatment. I think it really needs to be individualised. We've hammered that tonight. It's got to have the veteran at the centre. It's got to be multidisciplinary and collaborative. And it's got to involve evidence-based treatments which are augmented by complementary methods. And it takes time. And I'm going to throw out actual times. Like, these things don't get better in months. They get better in years. So don't lose hope. All the clinicians out there, you know, sometimes it's just time.
Yeah, good point. I quite agree. Okay, thank you very much indeed, Andrew, indeed to all our panels. I've just got a few quick closing comments, if I could. First of all, to remind people that MHPN supports local networks. Hopefully that slide is up. It's not working for me, but so they support local networks around the country that allow clinicians from different disciplines to come together and support each other and do some professional development and all that kind of stuff. And they run specific ones for veteran mental health. So if you're interested in those, it should be on your screen at the moment, I hope, the networks around veteran mental health. And if you want to start your own, by all means, contact MHPN. Otherwise, look in the resources and you'll find the appropriate one to join. I would also draw your attention, as we did before, to the resources. There are a whole lot of good resources there. As I said, MHPN will email you a link to those resources in the next few days. And I particularly draw your attention to the DVA at Ease website, which is especially good. Great stuff there for practitioners, for veterans, for families, and so on. So, but there's a whole lot of resources available to you there. So finally, I would just like to ask you, please, to fill in the exit survey. It's really important for us to know how you went tonight and how you found both the platform and, more importantly, the content. Otherwise, it just remains really for me to, first of all, thank the panelists very much indeed for their contribution. I thought it was a great webinar. They were a great panel to work with, so thank you very much to them. And thank you very much indeed to all of you participants for your questions, for your engagement. You know, it really is your involvement that makes these things work really well. So thank you to all of you. Thanks to everyone, and good night to all.